like Madam said, that 40 to 60 or even 70% women are affected by these gastrointestinal issues in pregnancy, like constipation and GERD. But now we are also seeing more and more women being affected by intrahepatic cholestasis of pregnancy and other liver issues. The mother is distressed because of the itching that she has, as well as the problems in her digestion. And of course, we all understand that the fetal implications are also there. And that is why these have become a highlight of discussion in these days. Today, we have none other than an expert in the field, Dr. Ajay, with us, who is going to be deliberating on this. Dr. Ajay Kumar is past president of Indian Society of Gastroenterology and past president for Society of GI Endoscopy of India. He is a former chairman of Fortis Escorts Liver and Digestive Diseases Institute. Currently, he is heading the department and he is the chairman of gastroenterology and hepatology at BLK Institute for Digestive and Liver Diseases. He has been conferred with several prestigious awards, including B.C. Roy Award by the President of India in the year 2008. He is also winner of the J. Mitra Olympus Award for the Endoscopist of the Year 2007 by ISG, and he has received many, many more accolades and awards. It is an honor and pleasure for us to be hosting you today, Dr. Ajay Kumar, and we are looking forward to your deliberations.
Thanks, Madam, first. Somebody can stop sharing. Thank you, Dr. Ahuja. First of all, thank you a lot for giving me this opportunity to be in this august gathering of leading gynecologists of the town. The topic assigned to me is to talk about some liver disease in pregnancy. It's a huge topic, very important topic. I will try to do my justice to it as much as I'm able to do that. Well, friends, liver disease in pregnancy sometimes, quite often, is not properly understood, and that's the reason which leads on to the moment we hear about that, it leads on to a lot of panic in the lay public, family of the patient herself, and creates a lot of scenes. So it's good to understand how do we approach that. I have tried to put my presentation as a case capsule formation. Before I go on to that, let's see what are we all know that pregnancy is a physiological, leads a lot of physiological changes in the different systems in the body. But it's important to understand here that SGOT, SGPT are the ones which do not change. As and when these are high in a patient, not in a patient, in a person who's pregnant, but prior to that they were normal, then we need to be concerned about it. But yes, normally alkaline phosphatase of a placental origin will be high, and that has to be differentiated if you are in doubt by checking the 5 nucleotide levels. 5 nucleotide levels will be high if it is due to the placenta, if it is due to the liver origin, and so is the GGT. So the moment somebody is alarmed at the height of rising of alkaline phosphatase in pregnancy, please check the GGT levels, and if they are high, then if they are normal, then rest assured that this is not due to liver disease. So after understanding, so regarding normal changes, so as I said earlier, AST and ALT, that is SGOT and SGPT, above normal level, should always be considered pathological. Most common cause of these abnormalities in pregnancy is pregnancy-induced liver disease. Coincidence liver disease may occur. Now, when we talk about liver diseases in pregnancy, we put it in 3 categories. The diseases which are coincidental to pregnancy means can happen to pregnant or non-pregnant or any other female or any other male as well. Patients already having underlying chronic liver disease of varied etiology and happen to get pregnant. Though if it is an advanced liver disease, the pregnancy is extremely rare, the conception rates are extremely low. But more important is to understand the diseases which are unique to pregnancy. And these are broadly, these are the 5 things that we talk about: cholestatic jaundice of pregnancy, hyperemesis gravidarum, and these two we can put in the same group, eclampsia related or a HELP syndrome, and the acute fatty liver of pregnancy. So we need to be clear how to differentiate. Some people have also put in a different category, that is the physiological changes of pregnancy causing worsening of some diseases and changes of Burchiari, hepatitis E, certain metabolic disorders have been attributed to that, and that's less clear. And this is pretty common. This is the best data that I could get from CMC Vellore, in which almost 8% deaths during pregnancy were due to the liver dysfunction. So look at this, the black thing is a pregnancy-related liver disease. Pregnancy incidental liver dysfunction is this, and as compared to the national rates of this thing, but it's important to understand that about 25% had jaundice out of 60,000 deliveries, and 8% died due to liver dysfunction. And it's a big number, and this needs to be sorted out. We have to understand it better to take care of it. Now, after we understand what is the problem, how big is the problem, and what is the issues involved, need for management for the expectant mother and for the unborn fetus, and issues, of course, to look at these 2 issues, you need to look at the proper diagnosis, therapy, and then prevention of these things. Before I go on to the specific case capsules, I put it in a table form. The hyperemesis gravidarum, first 20 weeks, supportive management. Intrahepatic cholestasis of pregnancy, usually 2nd and 3rd trimester, and we all know I will talk about that later. Acute fatty liver, 3rd trimester. Hypertension is the index thing that we need to follow, and we'll talk about that. Eclampsia, pre-eclampsia, the gynecologists understand better than me. And of course, the HELP syndrome, again, hypertension is the hallmark of all these 3 groups. Now let's go on to the case capsule that I have selected for today. Now, let's say 24 years old female, 16 weeks pregnancy, almost 2nd trimester, recurrent vomitings, inability to retain any oral feeds, and was noticed jaundice about 3 days back. See, when you look at it, the various possibilities will come to the clinician's mind. And I said 2 symptoms, when we were analyzing these presentations, 2 symptoms are very important, which I like to give due importance. One is the pain, and second is pruritus. Pain can be mild or absent in diseases like acute viral hepatitis, HELP syndrome, or drug-induced hepatitis. But when the pain is severe, that becomes the hallmark to look at stone disease, which could be incidental, or a biliary pancreatitis or other best. Same way, pruritus is a manifestation of cholestasis and is a hallmark of intrahepatic cholestasis, biliary obstruction, or drug-induced. So these are working as a slight markers for us how to approach further. If you go back to our patient had pain capillary, but this was dull ache for 5 days, and there was no pruritus. So when you look at these 2, pain and pruritus, this patient had pain, but it was a mild dull ache. Further on examination, this patient was afebrile. Vitals were stable except for tachycardia. Patient was clinically jaundiced and no evidence of any edema, no lump, tenderness on the right upper quadrant, about 2 centimeter liver, and no splenomegaly. So these are all the features that we examine when we see these patients. So if you come back to the different diseases that we can think of, is it a prodrome of viral hepatitis and with acute viral hepatitis, or acute hepatitis of any etiology? Could it be because the pre-eclampsia held? Well, this patient had no hypertension. If you look at the pain, because of the pain, you will think of cholecystitis, cholelithiasis, acute biliary pancreatitis, but the pain was mild. So if you look at this, because of the normal blood pressure and because of the mild pain abdomen, you can rule out these or put them in the back in your mind rather than. So the first thing becomes that could it be acute viral hepatitis? Investigations show that the bilirubin is gradually going up and the enzymes are high. And more important here to notice that SGPT is more than SGOT. ALT more than AST. Most of the non-viral or atypical viral hepatitis or atypical hepatitis, the AST will go more, but most of the viral hepatitis, you will find SGPT is more than SGOT. And the platelets, though, in the slightly lower, but this is normal. Platelets were normal, and no thrombocytopenia is a point to be mentioned. So patient undergoes various investigations of a viral markers, and we usually ask for hepatitis A. As you know, we do not think of hepatitis C as a cause of acute hepatitic illness because that presentation is extremely rare. So even B doesn't come as a first manifestation, but we have to think of A and E. But these are the 3 tests that we'll ask for. Most of these ladies have already undergone testing for B and C are negative, but you should look for these. Now, and then let's look at the various viruses, whichever one it comes out to be positive. Hepatitis A virus has a benign self-limiting course. Fetus is usually not affected. Intra-utero transmission not common. Hepatitis A vaccine is an inactivated vaccine, safe to use in pregnancy. Obviously, you will not use in this patient. And we do not advise hepatitis A vaccine as a routine in any of these. Treatment remains conservative and breastfeeding is allowed as far as this particular virus is concerned. Hepatitis B, we all know that there is a high rate of transmission. People have talked about vertical and horizontal transmission, but predominantly Professor N.C. Naik's study done from All India Institute and Kalavati Saran Hospital, probably the largest study in the world of the newborn babies who born to the hepatitis B positive mothers, have shown that most of these transmission is horizontal. That is the peripartum period rather than the antepartum or neonatal period because of the contact. So we should be aware of that particular thing. High incidence of chronic hepatitis in newborn if it happens at the neonatal age. You know, it depends at what age an individual acquires a virus. If it is in the newborn age, there is almost 70 to 80% chance that they will become chronic carriers. If the same virus attacks an adult, then the chances of becoming chronic carriers are less than 5%. So that's the reason it's a huge importance for us to look into this. Hepatitis B virus does not cross intact placenta. Transmission happens in peripartum period, as I said, very elegantly shown almost 35, 40 years back by that particular study that I'm quoting, and doesn't increase fetal morbidity except the risk of chronic hepatitis in the newborn. Newly diagnosed hepatitis B infection. So I said, while I'm on this case, I will discuss related features. newly diagnosed hepatitis B infection during pregnancy. So you have a patient who's got pregnant and you check that hepatitis B surface antigen positive. Currently, it's very clear that only those patients who have an active infection, which is determined by combination of two, and that is high STPT of more than 2 times upper limit of normal, plus high DNA, and then these are the indications for treatment. And if there are patients who have an underlying fibrosis, now today we have an investigation of a fibroscan to determine, though fibroscan is not currently approved during pregnancy, and but if fibrosis is significant, then again we like to give irrespective of these values. And if there is a normal or minimal elevated ALT, no or mild fibrosis, or there is a DNA is not high or negative, there is absolutely no indication of treatment. And currently, the drugs which are available are very good and safe. And I will like to say that the key drug of choice, preferred drug, is tenofovir. I've written. Tenofovir, it comes in 300 milligram. Then you have a TAF, which is more kidney safe, which is 25 milligram once a day. It is established safety, it is potent, and there is a low risk of drug resistance. It's considered to be safe in pregnancy. Now, the second question of prevention of perinatal transmission, I think all of you know better than me that the cornerstone of this is the vaccination and HBIG at the time of birth. HBIG 0.5 ml intramuscular injection, and the first dose of vaccine to be given, this is half the dose of the adult dose within 12 hours, and of course additional doses after that. And in a patients, earlier we used to give a lot of focus on E negative or E positive, but the role of HBIG is not clear. But anybody who cannot afford, I think the simple vaccine dose should do. Efficacy is almost 95%. And again, breastfeeding is not contraindicated. And now look at the E virus. Now this has become, since Professor Mohammad Sultan Khuru's study from Sopar in Srinagar, published way back, almost 40 years back, that HIV infection epidemic in Sopar, and then we know that the HIV infection is severe with a high risk of acute liver failure in pregnancy with a high mortality. High rates of preterm labor and maternal mortality. High rates of abortion, premature delivery, and fetal mortality. Prevention is the best. Whenever there is an epidemic in the area, you have to have a good personal hygiene, good water, good sewerage, and so on. There is no vaccine available today anywhere across the board. Treatment is same as any non-pregnant. Breastfeeding allowed. So we all know that there is a high risk of mortality. I think this is the group where people talk about termination of pregnancy. And like to say that there's no evidence that this works. This was a consensus statement of our Liver Society and FOXI on a published 2 years back, that to improve, see, there are 2 areas of concern, maternal outcome and the fetal outcome. To improve maternal outcomes, there is a little data to support termination of pregnancy if the mother has happy. Level of evidence to recommendation is strong on that. To improve fetal outcome, recommendation was individualized because the level of evidence is not strong. The recommendation is very poor. So that's the reason. Right now, I can say there is no recommendation to say that you should terminate the pregnancy to save the mother or the baby at any stage of pregnancy. Now let's move on to the second case. We have talked about one case, patient of acute viral hepatitis, which is not linked to the pregnancy specifically, but it is an incidental infection which occurs to the pregnant mother. Now let's look at another same 24 years old, 16 weeks, comes with severe pain, which is persistent for 2 days, say recurrent vomitings, no bleed, jaundice or obstructive symptoms, pulmonary pain. Patient is slightly higher blood pressure, jaundiced, tenderness right upper quadrant, liver 2 centimeter tender, and there is no other specific positive finding. Now, pain sphere, as I said earlier, if you are mild or absent, you think of acute viral hepatitis, HELP syndrome, or a drug-induced hepatitis. But when you have severe, you think of stone disease or a biliary disease or a pancreatic disease. And we have already talked about what we think of. This patient, severe epigastric pain, no pruritus, patient was hypertensive. And you look at the enzymes were high. So hypertension was another hallmark. And SGOT was more than SGPT. And platelets, look at this. Never ignore this part. And this obviously is taking us to somewhere else. So if you look at the differential diagnosis, you have a acute hepatitic illness, pre-eclampsia, eclampsia, HELP syndrome, acute cholecystitis, cholangitis, biliary pancreatitis, or acute fatty liver of pregnancy. Patient did not have any clear evidence of pancreatitis. Ultrasound shows no stones in the gallbladder, but the common bile duct was 8 millimeter, which is a higher. Normally it's 4 millimeter, with lower end not visualized. Viral markers negative. So you're ruling out biliary pancreatitis, viral hepatitis, fatty liver of pregnancy. Then you have a ultrasound and Doppler showing mild IHBR dilatation, that's intrahepatic biliary radicals were dilated. There's no liver hematoma or rupture. But when you look at the MR, that did not show any CBD stone, it showed an infarct, altered parenchymal signal in the liver, focal fatty sparing, and CBD was normal. Now, once you see the normal CBD, in a confusing case like that, though the CBD was 8 millimeter, you can ignore that. Because so now you have to, what you're left with is a last two diagnosis, one of the two, where hypertension here became the hallmark. So hypertension, so the patient had pain, but no pruritus, so you are coming at, and low platelets as well. So hypertension more than 140/90 on 2 readings, that's what you people taught us all the time. Proteinuria more than 300 milligram in 24 hours on spot estimation. Gestational age more than 20 weeks. Normal blood pressures earlier in pregnancy, that's also important too. Treatment options depend on gestational age and severity criteria. I think these are the various severity criteria of preeclampsia, which I will have to rectify, but I think all of you people have on your tips. HELP syndrome, as it stands for hemolysis, elevated liver enzymes, and low platelets. The answer is deliver the baby. I think this is the key issue. You have to deliver the baby if you are looking at, and dexamethasone is not effective. So the HELP syndrome, the different Canis classification, Mississippi classification, all that we know that. So that management depends on the gestational age. People have talked about patient to be stabilized over 48 to 72 hours. But the problem is you have always in a quandary here how far you should go to put the mother at the risk or to put the child at risk, or to make the child safe, or to put both mother and child at risk. That's the dilemma here. So less than 34 weeks, people say consider steroid for 24 to 48 hours for the fetal maturity. Of course, antihypertensives, I believe amlodipine is the good choice, but I think I'm not the expert on that. Magnesium sulfate intra and early postpartum for seizure prophylaxis. So see this patient underwent termination of pregnancy and see how the parameters improved. You look at the platelets were stabilizing, but you look at the other parameters. So started improving clinically and biochemically. The mother got well. Of course, child could not be saved. But then mother, this is one of those areas where the clinician is always put under pressure by the family, by yourself, by your conscious. You have to take are you taking the right decision? I think that's where we need to update ourselves. And similar syndrome of acute fatty liver pregnancy, we always face that issue. That's another area where you are immediately advising termination of pregnancy. These are the Swensia criteria, 15 criteria. They say 6 or more of 15 were required in the absence of another cause. And now these have been put in a simplified form. This also I copied from that same article from CMC Vellore, the simplified criteria that you have a setting of a late pregnancy, acute liver failure, and there's no other explanation for liver failure. And then you start thinking of acute fatty liver of pregnancy. You are not possible to do a liver biopsy in every patient because it's important for the future pregnancies also, but these people are susceptible to that. And but here again, immediate termination of pregnancy on diagnosis, and cesarean may be preferred, and baby has to be observed for hypoglycemia. I mean, so these are the two most important conditions which are exclusive to pregnancy. Now I'll take I think I've got some time left, but I'll take the last case. Same age, same week of pregnancy, notice jaundice, associated pruritus. Now we come back to pruritus. And as I said, when you have pruritus, intrahepatic versus extrahepatic is the key issue. If you have fever, upper abdominal pain, cholangitis, alcoholic disease, or a viral hepatitis, then you think of that. Prior biliary surgery, you always think of a biliary complication. Presence of extrahepatic disease, drug history last 6 weeks, especially the lot of, especially the anabolic steroids, supplements which becoming more common in the young males who go to the gyms and all that, or some alternative medicines which can cause that, misuse of them which can cause that. Of course, family history of cholestatic disease, all these pictures have to be noted. So if you look at intrahepatic cholestasis of pregnancy, intense pruritus in pregnancy starting in the 2nd or 3rd trimester. Earlier on, Dr. Mentioned that it's getting very common in northern India. We also get a lot of patients with those which are obviously most of them referred by the gynecologist colleagues. And the thing is that we call it intrahepatic cholestatic jaundice of pregnancy, but most of them may not be jaundice. Actually, they are not jaundice. They basically have pruritus, and they can have a significant rise of transaminosis. Actually, whenever in doubt, the serum bile acid levels become important. Fortunately, now we have them available. Earlier, we didn't have these available. But I think that's up to 10, they say more than 10 levels, it's important. But levels of bile acid also correlate with the severity. And they say that more than 40 leads on to more problems. And spontaneous signs and symptoms after delivery within 4 to 6 weeks. And 0.4 to 2% incidence during pregnancy. I'm not too sure what is the incidence in our northern part of the India, but I believe it is on the higher side. Increased fetal complications, both premature birth as well as the stillbirths. And early induction at 37 weeks is recommended to prevent these two complications. In selected cases with very high bile acids, more than 100, people believe that you can do even earlier than 37 weeks. Now, there is no consensus on that, but that's one point which is important. And there is no increase in maternal mortality. So it's mainly risky to the baby, not to the mother, right? So the treatment, category B drugs, ursodeoxycholic acid, 10 to 15, all of us have been using this, and they are reasonably, from symptom-wise, is quite helpful, but it doesn't change the outcome. I mean, the people have said it improves the fetal outcome. Obviously, that's what we are looking for. But just because they are improving, that does not mean that we change our decision of termination at 37 weeks. The people have used S-methionine, and this not superior to Udka. It could have an additive effect. Very little data. I personally don't have much use. It's available easily. I don't use it very often. Cholestyramine I don't use because very few patients tolerate it. A lot of dyspepsia and intolerance in that. Drug-induced cholestasis is another entity. They say isolated elevation of alkaline phosphatase. ALT-SAP ratio goes up. Better prognosis than hepatocellular injury. There are no specific diagnostic tests. It's only the history from the patient which gives the diagnosis. And normalization of the liver function can take up to 3 months. The other differential diagnosis with pruritus is a gallstones, and certain things which I thought I like to, which are important for the decision making. I'll sum it up here. Gallstone disease may develop during pregnancy. Gallbladder sludge and stones may disappear after delivery. Biliary colic alone should be managed conservatively, pain relief. Asymptomatic gallstones are to be left alone. Acute cholecystitis, discontinuation of the standard regular management, conservative management has been mentioned here. Now, decision of surgery, earlier it is done, better it is, but we should avoid laparoscopic cholecystectomy in the third trimester. I think that's the lesson from here. Otherwise, it's safe to do it. If it is acute cholecystitis, better to do the surgery rather than risking for the third trimester when it will be more unsafe. Bile duct stones, which requires ERCP, is a potentially life-threatening for the mother as well as fetus. ERCP has to be done. The risk here is of a radiation exposure. And first trimester, any endoscopy is to be avoided. But second and third trimester, you can easily go for it. And ERCP, the main problem is how to protect the fetus. You have to minimize the radiation, use the appropriate lead sheet for that, and minimize the fluoroscopy time. Here is my second last slide. Workup of pregnant women, initial work of abnormal liver tests. Look at the clinical symptoms. If there are more of pruritus, look at the biliary profile and check that. And if more of a transaminases, then hepatocellular profile, rule out viral hepatitis, drugs, and so on. And I have not even checked for here that autoimmune hepatitis, which are also more common in the ladies. And if there is no evidence of obstruction on this side, then pregnancy-related workup, which I have talked about, and the management will depend on that. Here I have summed up what I was talking earlier. Ultrasound is a safe and preferred imaging. Strong, this is a recommendation, strong recommendation. MRI without gadolinium second to third trimester, without contrast. CT scan is teratogenic and childhood hematological malignancies, so you should have a judicious use. Protocol is 2 to 5 rads. You should be careful about that. Endoscopy, safe in pregnancy, but is deferred till second trimester if possible. Propofol can be safely used for endoscopic sedation in these patients. Biliary disease, ERCP, minimizing exposure to fluoro is imperative. And symptomatic gallstones, early lap surgery. So these are the American College of Gastroenterology's recommended guidelines in the pregnancy, use of the various modalities. So friends, I conclude my presentation by saying that need to understand the various clinical challenges and make a proper diagnosis. Be cautious but not panic, because that will help on cooling down the family because who are actually in panic at that time. Only few conditions which need termination of pregnancy, like fatty liver of pregnancy or eclampsia. Most of the time, conservative approach helps. Thank you very much.
Thank you so much, Dr. Ajay Kumar. I think this Sunday has been really delightful because with the wonderful weather, which has been a visual treat, I think your talk has been an academic feast for all of us. We've really got enlightened today. And I think I was glued to my screen and taking pictures throughout of all your slides because they were really enlightening with all the problems that we see these days. Thank you so much for sparing your afternoon for us.
Thank you.
Dr. Mala, do we have any questions from the audience?
Yeah, we have quite a few questions for both our star speakers. There is a question, what is the role of progesterone in intrahepatic cholestasis of pregnancy for madam? Ma'am, you are muted.
Ma'am, you're still mute.
Just
हाँ जी ठीक है मैम आ गई आवाज.
see what we find is I find more than the progesterone the history of previous when you've taken an oral contraceptive pill, and if you find there is a history of pruritus, that is significant. So if that particular history is there, if there's a past history is there, Definitely, there's an overuse of progesterone is seen after ART cycles, and to that extent, I say that progesterone definitely has a role. Dr. Ajay probably is going to make the final comment on this.
Madam, I think I agree with all that. There's nothing new in this.
There is another question for Sir. Almost all ultrasound these days reports fatty liver grade 1 to 3 across adolescents to elderly. What is the importance of this diagnosis and how should it be counseled and treated?
The cleverly, all the radiologists underneath they write, please correlate clinically. So they leave it to you to correlate with clinical. Fatty liver is a new epidemic. It's not exactly the epidemic like an infectious disease, but it's a new radiological epidemic. And we also see in it, actually the incidence has increased. I will not, if you look at pregnancy-related specific issues, if the liver functions are okay, I will not get too much into that, and I will ignore it till I sort it out. Now, managing a fatty liver in otherwise is a huge chapter, but I'll sum it up in few lines. When it is there, we look at how much is the fatty liver. The best investigation for that is a MRI or CT with a special software, but we rely on a most non-invasive thing of a fibroscan. It shows us the CAP values of a high or not. And whether, fatty liver, whether it's a inflamed liver, that is a hepatitis, or it is a simple fatty liver, is the key hallmark. And the second hallmark is whether there is a significant fibrosis. And we are only worried about fibrosis. And so if fibroscan doesn't show any fibrosis, and today we don't have any specific investigation short of liver biopsy to differentiate between simple fatty liver or simple fatty hepatitis. We have a lot of investigations for fibrosis, but fibrosis is a complication of hepatitis. So we look at liver enzymes, and in extremely rare cases, we'll resort to a liver biopsy in that, not as a routine. But if we look at the risk factors, so the risk factors, diabetes, hypertriglyceridemia, and overweight, or any drugs. These are the 4 things that you need to look at and focus on those 4 things. Even if you find out that the disease is more than normal, still these 4 are the main treatments, and no specific drugs. And if in an odd patient, we have to use drugs, then we go for a vitamin E. I think I'll stop here for this. I think this is just a brief, but in pregnancy, unless you have evidence of an associated chronic liver disease in the form of fibrosis, I'm not going too much of importance to it.
Thank you, sir. There is a question for Madam. Is it necessary to measure bile acids level in fasting state?
Will you repeat?
Ma'am, is it necessary to measure bile acids level in fasting state? Bile acids.
This is the recommendations. This is the recommendation that this bile acids should be done in a fasting state. And what is the relevance? I will not be able to comment on it. This is this
in
is
our hospital, the practice is to have bile acids in fasting state. We always advise.
Yes.
Sir, what is your experience on using anesthetic antacids?
In basically you're
pregnancy,
talking gastroesophageal reflux disease.
Yeah.
I think basic approach in managing any disease in pregnancy is to minimize the medicines. I mean, though we know it's a safe category A, B, C, whatever it is, but still we do not like to use the medicines unless we are forced to, especially the medicines which are absorbed. So antacids, and even otherwise, once in a while heartburn, the SOS antacids are better. But for the long term, we do not recommend antacids. If there's somebody who requires a long-term antacids, it's better to go for a H2 receptor antagonist or a proton pump inhibitor.
Thank you, sir. There is a question from Madam. Is there a role of emollient antihistaminics in intrahepatic cholestasis of pregnancy?
The drug of choice, doctor has already told you that we use this particular salt, what we call glutamate. And this is pretty effective, but as he has very already pointed out, that it gives us a false sense of security. We must follow the dictum that early delivery is indicated. Early delivery is indicated. In no way we should go beyond 37 weeks. And after 32 weeks, these patients must have a very close fetal monitoring, because suddenly, sudden IUD can happen in such particular patients. So we have to be very careful. A decade earlier, we were not so much aware, but from the last 10 years, we have become very sensitive about this particular thing. And naturally, a patient is sitting whole night. You have to give something, calamine lotion, something of that particular kind. You have to do a supportive treatment of that particular kind is given.
Thanks, madam. There is a question for sir also. How do you select a laxative for your patients amongst the safer ones available?
I think Madam has given a wonderful summary of this thing. The osmotic or the other one, or the basically the thing is to avoid the laxatives which can be harmful, and we do not like to use the stimulants. And out of the two things that we talked about, polyethylene glycol and lactulose have the best evidences. And polyethylene glycol probably becomes in the lactating mother, we prefer to use the polyethylene glycol based ones, while in the pregnant mother, both are equally safe and effective.
Thank you, sir. Last question for madam. How long doxylamine and pyridoxine can be given in nausea and vomiting of pregnancy?
This is a very interesting thing. I just must share with you what is the policy abroad. I have many of my relatives who have had a pregnancy in US, including my daughter. The policy over there is no antiemetic drugs to be given. If it bothers you, come to your emergency room and we will take care of you. And this is what the policy is they adopt. And by the time they hear the name of emergency room, the family has to spend a lot of dollars there. So their vomiting disappears. So that is the policy. That is the policy the doctors in the Western world have as far as the vomiting is concerned. We do pamper our patients here, and we use left and right. But some are very safe drugs. People like me follow that particular policy. I always tell them that you should increase your ginger preparations in your diet a little bit more. Vitamin B6 already is the part of the folic acid we are giving them. And as such, people like me do not give these drugs. I have seen doctors giving MSET injection for a simple vomiting. And I am going to take next time the vomiting in pregnancy, where MSET has been known to cause increased cleft palate incidence by 3 times. So I think we are going to cover that particular topic next time. I have told you what is my policy as far as the antiemetics are concerned during pregnancy. I don't use much.
Thanks, ma'am. Question for sir. When can UDLIP be started and how long should be given with patients with intrahepatic cholestasis of pregnancy?
I think that whenever we diagnose, we can start it, and it can be given, it's a safe drug. I mean, it said we safely use for as much time as possible. So we usually like to give till the termination of the pregnancy at 37 weeks. We'll recommend that.
Thank you, sir. Another question has come up for madam. What are the genetic linkages of intrahepatic cholestasis of pregnancy? Is family history important?
Yes, recently I heard about it that there is a family history is important. Not only the past personal history of yours is important, but the family history of intrahepatic cholestasis is also important. Otherwise, people having a fatty liver and having a problems in the pregnancy, in otherwise also in the family, it is important. I think Dr. Ajay Kumar will be probably the best person to make a comment on this.
There have been genetic studies. I am not fully aware. Right now, I'm not offhand, I cannot quote that. There are genes which have been expressed and which have been told to be responsible. So there could be some genetic factor in that. But family history, yes, it is important. It's just like more common in the children who have, the mothers also had the same thing. Other than these two, I won't be having more information.
Thank you, sir. Another question is popping up. Which antacid is most safe in pregnancy?
Antacids, I said that wherever the bicarbonates are, that should be avoided because a lot of salt is going in that. So otherwise, the safe ones are what we are using, a Gelusil or a Dialgene. But again, it has to be for a very limited time.
Which is the safest antihistaminics for pruritus in pregnancy, madam? I thought that previous was one last question, but again the questions are coming up in the chat box.
मेरे जैसे तो levocetrazine use करते हैं.
What is the treatment for excessive salivation in pregnancy?
I find this is a bothersome symptom for at least 2 or 3% of my patients. I have no solution except I tell them bhai ilaichi kha lijiyega. Dr. Ajay Kumar is going to speak something about it.
अगर मेरी बीवी को होगा तो आपके पास ही भेजूंगा जो एडवाइस के लिए.
See, the question is, all these patients, I tell them that if you have it as a bothersome, you please come down for 2 days, get admitted with me. You find all their symptoms will disappear. I think they require counseling, little more time, what is bothering them at home, how it is things are done. So I think, that particular factor is very, very important, that you give them 5 extra minutes.
Sir, last question for you. What should be the safest and maintenance dose of laxative in pregnancy?
See, I think the first question was more relevant at which laxative. But the dose is wise, like once it is, we say safe, any dose is safe, it depends upon the effectiveness. Then what is the requirement of that particular patient for that particular laxative? You can keep on increasing till the side effects are not there or it's not effective. Now, question is, you can combine the two. Yes, you can combine. You can combine it with fiber, polyethylene, and lactulose, whatever suits the patient. Question may come of the recent secretagogues like the chloride channel, lubiprostone, or the HP4 receptor, the
People like me will.
I'm not very fond of prescribing these two relatively newer drugs in pregnancy. They may be safe, but we are not too aggressive in using those.
People like to say that over-treatment is bad as far as the laxatives are concerned. They should not do it.
There is a question, can laxatives be given during the entire pregnancy?
Yeah.
Yes, whenever it is bothersome, these are the emergency calls to the gynecologist. So you need to tell them, in fact, when they have exhausted all elders, what they say in the house, this sab gul le lijiye beta, ye le lijiye, wo lijiye, when it doesn't work, then they bother. And then you have no other solution but to talk about lactulose and PGR. But what I feel is these gummies are good and they can take 2 tablets and you need to try it out yourself.
I think so last question has come. Your experience of Live 52, evidence-wise, what is the take on that? Sir?
I haven't used Live 52 in my entire professional career. And a lot of patients who have been taking Live 52, I have stopped it as well. So I'm not the right person to talk about its effectiveness. It's from the alternative system of medicine. They have the best experience with that. And even if I have to answer from their perspective, Live 52 is a combination of the multiple herbs. And out of that, one of them is a Philanthus. And Philanthus is something which has undergone trial for the specific use in hepatitis B, right? But it was not reproducible, so we do not know the answer from that. So even Ayurveda people do not usually talk about combining the various herbs, and they basically are looking at herbs which are grown in that particular geographical area where they are residing, because that is the right environment for them. So it's a very complicated question, but I think I cannot comment on that more than this.
I have one thing, what fatty liver question was asked by Dr. Ajay Kumar very, very beautifully. And I think, that was a masterly answer. There is an epidemic of fatty liver. And he has definitely said that we need to differentiate between inflammatory and a fibrotic disease. Fibrotic disease is bad. And once ultrasonologist explained me, Madam, FibroScan is available, and that particular test will simplify your problems. If you find that the fibrotic element is more, hand over that particular patient to the liver experts. You will not have problems. Don't keep on doing anything. And goes without saying that all these patients need to reduce and take a lifestyle measures to correct all that kind of things. If they decrease their weight by 10 kg, things will be definitely much better off. And they have to change their diet pattern in a very big way. Dr. Ajay, we would like to hear again on the fatty liver, because this is becoming really a problem.
So it can be a regular talk on fatty liver rather than fatty liver in pregnancy.
Yes, we will have a talk on a fatty liver. That's it. I think that will be a good thing, because all of us, all allopathic doctors who do not have any treatment with us, I think we must know what is the right approach. So, Madam, wind up for Dr. Meenakshi.
Yeah, I thank you so much. I think today it's been a wonderful day and a wonderful treat for all of us. Not only have we heard Indian statistics about liver disease from Dr. Ajay Kumar, we've learned a lot of practical tips and personal experiences. And also, I think the case sharing was really, really good for all of us, because that was probably the most practical way and the most absorbing for all of us to keep glued onto our screens for the best part of our Sunday afternoons. Thank you so much to both our speakers, Dr. Sharda Jain and Dr. Ajay Kumar. Thank you to my co-moderator, Dr. Mala Srivastava, who was so patient with all the questions. And of course, a big thank you to the audience, because obviously when they had so many questions, that means that they were glued into their screens like both of us, Dr. Mala and I, were throughout the session. Thank you so much to the audience, and thank you to Abbott for getting us all together on this platform. And we hope to have more enlightening talks in the future soon. Thank you to all of you, and have a great evening.
This gastroenterology division of Abbott definitely have decided to create awareness among gynecologists on various gastrointestinal issues. So we will definitely have these kind of session little more and involve Dr. Ajay Kumar for the same. Thank you so much, Dr. Ajay. Thank you, Meenakshi. Thank you, Dr. Mala.
Thank you.
Hi, ma'am. Achita, are we